Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Hi, George. It's Tuesday morning, and we have a fabulous guest on today.
Yeah, welcome. Today we have the famous Dr. Nola Ernest, and her topic is going to be a very interesting one. Taking back your voice, getting pediatricians ready to be agents of change and ring the bell.
Absolutely.
Yeah.
Well, Dr. Nola Ernest is a community pediatrician, and she's also a huge advocate for pediatric issues, pediatric workforce in children in Alabama. And she's also the chapter president for the AAP in Alabama. She is a phenomenally nationally recognized speaker and someone that I really enjoy talking to. So thank you for joining us and welcome to the show.
Thank you. Thank you for having me.
Yep.
We always start at the same place. Why did you choose pediatrics?
And I love that question. I ask it to my colleagues as well. One would think that pediatrics was a natural fit for me. I am one of 10 children. I grew up in near poverty in a rural area in Louisiana. And I was always taking care of kids since I was born, really. I was always part of that caretaking group. My mom said that I had said I was going to be a pediatrician from a very young age. And I don't remember that. I will tell you that by the time I got to high school, that the voices that I heard from my extended family and my community had really impacted me and shaped my perception of myself. And by the time I was in high school, I did not think I was smart enough to go to medical school. And so I actually went to college initially to become a physical therapist. And my journey back to pediatrics took several steps, but the most important of which actually came finally in my pediatric residency. I was called to the bedside of an 8-week-old infant who was admitted for non-accidental trauma and liver failure. And the nurses were asking for oxycodone because he was fussy. And that was a reasonable request, given his liver failure. He couldn't have other things for his non-accidental trauma. But I went to the bedside of this baby and I swaddled him and held him and gave him a pacifier, and he just immediately soothed. And what he really needed was someone to take care of him. And at the time, I was actually, by that point in my journey, in residency to do pediatric neuro-oncology. But that was the moment that it clicked, that I really cared for children and I wanted to be that community pediatrician that supported families in taking good care of their children.
Wow. Let me ask you, you referenced something about your family and your community, and you thought you weren't smart enough. Were they biased that women are not smart enough to be doctors? Is that what you're telling me?
Yeah, I think there were a lot of biases there. So I heard a lot of messages. I am a survivor of childhood abuse. And so one of the messages that I heard was that I had a position and that position was not worthy of seeking more. But I also had a lot of voices from my community that just said, people from our community don't do this. Poor kids won't be able to afford to do this. You're not going to get scholarships. And if you don't get scholarships, you're not going to be able to afford to take this path and you're not going to be able to do it. And in some cases, they're still right. Medical school, because of the cost of medical school, can be very burdensome to people who grow up in low socioeconomic communities. And they may not even take that step to pursue that.
Well, I think that's a real problem, not only for, I think anybody that's not upper middle class and wealthier. The kids are graduating with debt of $300,000 and more.
Absolutely.
After an 11-year journey, and it's your 20s. So the best decade of your life is spent educating yourself, and you're $300,000 in debt, eating Roman noodles. that's a difficult journey if your mom and dad don't have the money to pay for that school and buy you a car and keep feeding you. Extremely difficult.
Right. I was blessed because you know, like I said, my journey took several steps. And one of those steps was that I did pursue my PhD alongside my medical degree. And that helped me to pay for medical school, that they did subsidize my medical school there. So I was able to take out fewer loans because I didn't have to pay for tuition. And I had a small stipend.
Oh, nice.
But
Yeah, but that was a longer road now.
Right. I always tell people I went to the very long path of getting through medical school. I work with a colleague that was in my first year class of medical school, but she graduated 4 years before I did. So it took me a much longer path.
Yeah, but now you have a lot of initials behind your name.
I do have a lot of initials behind my name. I don't always put those to use, but I still think that it helps, having that PhD and knowing, having that background in bench research. I'm really able to look at scientific studies and pick them apart and talk about the data with families, the few families that want to know that kind of thing when they come and ask me about questions. And I will say, because my PhD happens to be in neurobiology, I am I have some unique expertise in how the brain develops. And so when there are questions, for example, my families have about vaccines and autism, I can point them to the data, but I can also tell them, I really understand how the brain develops. That is part of my journey, is learning about that. And I don't have any concerns about this for my own children.
Wow. And so you did say you thought maybe you were being an oncologist, but once you decided you were a community pediatrician, did you always think you'd go back to a small rural town?
Yes. And so my husband and I met my husband in medical school. He is not a pediatrician, but he also grew up in a small rural town. And both of us had that experience of growing up in an area where we had to drive 45 minutes or more to go into the city to see a pediatrician. And so when I graduated residency, he and I together knew that we wanted to go to a place where pediatricians were needed. And so we only looked at jobs in small towns where there was great need for a pediatrician. I did have offers to open my own practice, that the hospital would help me to open my own practice in a small town. But at the time, I did not feel comfortable doing that. I did not think that I would be able to take the lead in a practice, not having a lot of other knowledge at that point, not having that business acumen and not knowing how a practice was run. I didn't think going out into career that I'd be able to do that. So I actually started at a federally qualified rural health center that was ready, open and running, and then joined my practice a few years later and became owner after that.
And so this practice is a private practice with multiple locations, right?
Mm-hmm.
Throughout Alabama.
Yeah.
And they're all in small towns. I mean, I looked at your town, and your town has like 25,000 persons in it.
Yeah. And our location is actually in one of the larger towns. So we have a location in Ozark, Alabama, which is smaller than Enterprise, the community that I practice in. We have a location in Eufaula, which is very rural and very small. And our big satellite location is in the Dothan area, but Dothan is still a rural community that we don't have any interstates that run anywhere near us. The closest children's hospital requires a 3-hour drive for most of our families. And so we're really in a rural, underserved area. And that was what drew me to my practice. So the practice that I am in has actually been open for 70 years this year. And wow. I came on about 6 years ago as an owner. But the mission of the practice is to provide access to quality health care to all children of Southeast Alabama. So we really are looking to continue to reach out to the communities in Southeast Alabama. In Alabama, there are 23 counties that do not have a pediatrician to serve them.
How many physicians are in your group?
In our group, there are 21 physicians and currently 11 nurse practitioners.
Wow, that's a big group. And you're all owners?
No. So there are 10 owners.
10 owners. Okay, that's still good.
Well, and we benefit from, yeah, right. It is. Sometimes it's 9 owners too many. But we keep each other grounded. We are all physician-led, physician-run, and we do hire intentionally. We hire people that think like us, and so that are very evidence-based. And when there are new guidelines or new recommendations for things that we should be doing as a group, we can turn that around really fast and start implementing those guidelines, which I really love. But we do benefit from the economics of scale, and that allows us to have employed physicians that don't want to work full time. We have employed physicians that work, 2 days a week, 3 days a week, 4 days a week. Right. Some of us old guys still work 5 days a week, but that is becoming less and less common. And so really, because of our scale, we're able to offer, kind of a make your own career path. If you want to move towards partnership, you can. If you're not interested in moving towards partnership, you don't have to. You still work for some really great guys and be able to provide excellent medical care.
Wow. So is it hard to find physicians?
Yes. So it is hard to find physicians.
I always the only thing I know about Ozark is the series Ozark.
Right. I tell people it's very difficult to convince people to come and look in Southeast Alabama. It's not difficult to convince people to stay because we do have such a great practice. We are able to support pediatricians really well. We are close to some really beautiful beaches. We have actually a really good school system in our area. And so there's not a lot that pulls people back away once they get here, but convincing them to come and look. I had a colleague in Washington State that was talking about his federally qualified rural health center and the difficulties that he was having in being able to affect change in his group. And I said, hey, come on, let's talk about getting you to South Alabama. And he said, Nola, have you looked at me? I'm a very Black, very gay man. I am not moving to Southeast Alabama. and that is a fair statement. And I told him, I said, I can't do anything about racism and bigotry without representation. So I still wish you would look. But for those reasons, it's really hard to get people to come and look.
Yeah.
How was your practice when you worked at a federally qualified health center and now you have a private practice, two opposites? What is the difference between a private? You seem to be more happy in private practice, right?
Yeah.
You're smiling all over the place, so it must be a good thing.
And I'm happy, but not because I'm seeing fewer patients. I actually am one of the busier pediatricians. If my personality, you see me in action. I'm kind of like a chihuahua. I'm always bouncing and moving. So I'm a physician that sees 40 to 50 patients a day, not because I have to, but because I need to keep moving. But I'm able to do that because of the support in my practice. Our practice's belief when it comes to doctors is that the doctor should do what only the doctor can do. We should not be filling out forms or spending a lot of time on administrative responsibilities. We shouldn't be having to, work on our electronic medical record to try to tweak things. We should hire people to do that and then just focus on seeing patients and providing excellent medical care. So in the Fairly Qualified Rural Health Center, whenever you wanted to make a change to the care you were providing, I had to ask for permission from the medical director, who had to talk to the CEO about it, who had to bring it to a board of non-pediatricians to ask them if we could do things. And we weren't doing fluoride varnishes. We weren't doing developmental screens. And that really hurt. I mean, these are basic pediatric tools. And now I'm able to do those things with the support of really the entire group, because we all have the same values when it comes to caring for children.
A lot of people feel, hold on, Herb. I see a lot of physicians that they equate being happy to seeing less patients.
Right.
I don't know if that's right.
It's not.
No, I equate being happy with being able to provide what I believe is excellent care.
Do you
And
go home on
having that,
time? Do you go home on
and I
time?
get home on time. Oh yeah.
That's
Well,
happiness right there.
it
Go home on
also
time.
helps that I live, 10 minutes away because I am in a rural town.
Right.
But I leave at 5 almost every day. And if I don't leave at 5, there's a very good explanation for it. Like the last patient of the day turned out to have new onset type 1 diabetes, and I had to
Yeah.
get them, packaged up and moved to another facility. But I leave at 5 almost every day. I'm home, 10 minutes later and get to have dinner with my family. I eat lunch every day. It's actually a important sticking point in my office. I make sure that my staff eats lunch every day. If, again, for some reason we're running late in the morning because something happened that was unavoidable, then I will buy lunch for the staff and make sure that everybody has a time to eat. That is part of it. And the only way to do that is to hire that support. I mean, we have people that only do forms. We have people that only do PAs. We have people that only do callbacks. And that is their job. But when you're able, and again, economics of scale, that probably would not be affordable for a smaller group, but they're doing the callbacks for 5, 6 locations now. And so if you're able to see one extra patient a day because they're doing those callbacks and getting those patients in,
Right.
for all of our providers, that pays somebody's salary.
Correct.
So we're going to get more into this in a little bit, but you just basically described everything that Dr. Dean talks about, the reason why physicians feel such moral injury. And you then described the solution. But let me ask you before we get into that, what are your goals as the president or chair of the AAP chapter in Alabama? If you have 2 or 3 main goals you want to do while you're there.
Yeah. So my main goal has been and continues to be to involve as many pediatricians as possible to hear their voice. So we've already instituted a periodic member survey to try to get more, to hear what the concerns are of our members, to make sure that our board stays focused on what the member needs are. But in order to hear from them, I really need them involved, right? So I can't stay member focused if I don't have the engagement of our members. And so I've been going to low member practices and low participation practices, reaching out to them, whether it's in person, email, webinar, or just handwritten card, and inviting them to participate with us. We're trying to get as many pediatricians plugged into committees, not just AAP committees, but state agency committees and work groups as possible, and just getting as many people to recognize that they do have importance, that their identity and message, their voice is unique and important to me, and finding a place for them to plug in and use that voice.
So I need to understand a little bit better. The AP is an interesting organization because, as I understand it, the AAP Virginia or the AAP Alabama, they're not the AAP. They're independent chapters, and you have to get membership dues at the state chapter, and you have your own board, but yet you're somehow kind of overseen by the AAP in Chicago?
Yeah, so the national provides us with support, and then obviously opportunities for things like grant funding. But you're right, we are a separate organization. We're connected to the chapter. We're connected to the national organization. We're able to send representatives to national to have Alabama pediatricians' voices heard in a larger scale. But we are a separate organization that really focuses on advocating on behalf of the children and pediatricians of Alabama. And that is our primary focus here.
And so when you say your board, you mean the chapter board at the Alabama level, so that pediatricians' concerns are being heard in Alabama.
That's correct.
But to translate that to the pediatrician having concerns in Alabama to the board in Chicago, that's another mountain to climb.
Right. That's another hurdle. So we have to take those concerns upwards. And part of that involves getting more Alabama pediatricians into into committees, so into the national level committees. We just had our CME chair was just appointed to the committee on CME for nationals. And so that helps. And then of course, our participation in leadership conference and writing resolutions and being there to vote on resolutions and debate. And I am a very vocal pediatrician on behalf of Alabama pediatricians at leadership conference. And we actually earlier were discussing how to get members to vote in our election. And actually our district offered a resolution on that this year because we also agree that in order for your state pediatricians to be represented in national advocacy, that you have to really be heard. We need more state pediatricians more pediatricians at the local level to participate in things like elections.
And what was the resolution? What was the resolution?
The resolution was unfortunately, there's not a lot of teeth in it. The resolution is to look at incentivization programs for voting. They tried that a couple years ago when voting was still with the NCE, a few years. And I think based on a recommendation from Katrina Skinner, actually, Dr. Skinner had recommended that voting be part of what we do at NCE. And at the time, they had started an incentive program where you got a discount, at the shop AAP for the conference, if you voted. I would love to see the numbers on that. I want to know, the data. What were the results? Did that actually help? What have our voter turnout rates done since we changed the voting back to be before NCE? Does the timing help? And so we really are trying to task the board, now the national AAP board, with looking at voter turnout in a more evidence-based strategic way, in kind of your quality improvement cycle, make a plan for the incentive program like they did before, but actually study it and see what impact it has on voter turnout to see what we can do to increase those rates.
And so the last time someone quoted me, they told me that only 17% of pediatricians that pay dues to the national organization vote in the elections. Mm-hmm. And my response was to that, I'm a data nerd, so my response to that is a poor reflection on the leadership of the AAP at the national level. Because when only 17% of your people are paying dues to you and you're a member organization are interested, that means you have a huge engagement gap.
That's exactly right.
And so I applaud you for listening to your pediatricians, because I hear more often than not from pediatricians, why would I bother? The AAP doesn't listen to me.
Well, there's some of that, but also I voted last time around. Let me tell you, it wasn't an easy task, and I'm pretty good with computers. You got to log in. There's now it works better with the logins. It used to be your AAP number that I never would remember. Now they put it to your email address. You'd log in, you'd find the button inside to where to vote. Then you had to click that. There's like 5 or 6 clicks to get to where you got to go. It should be a button here, vote for the AP president. Boom. Pick one.
That's one of the things that's
simple technology. It's simple technology. It's really not that complicated.
The national AAP has had a technology problem for a long time.
Yes. They have a lot of good content though.
Yeah, they do have good content, but
you can never find it.
Whether or not you can find it is the question, right?
Yeah. So most people are busy. I don't want to be spending 5 minutes, even if it's 5 minutes, to look for something. that.
Right.
And then if you have a little bit of apathy, like Herb says, it's finished.
You're done.
Yeah.
You're done. If people don't feel like they're being heard, why would I even bother with the email? It just goes into junk.
Yep.
And that's
Move on.
what we hear at a local level too. We actually have quite a high percentage of our pediatricians in the state are chapter members, local chapter members. But the ones that are not do say things like, why would I join the AAP? What has the AAP done for me? And at a chapter level, that reflects to me that they are not seeing what we're actually doing, because I am advocating on behalf of pediatricians every day, and the increased payment rates that they see, or their, kids getting to get CPAPs, that is work that the chapter has been doing every day to advocate on behalf of pediatricians. But again, like Herb said, that is a reflection that we are not showing that, right? So somehow there's a disconnect between the members and the leaders, and they're not seeing what we're doing. And that's really where my focus is getting them more engaged so they can see what the chapter does for them. And I wish we had more of that at a national level, because I know similarly, especially through SOPM, that there are many things that the chapter does, that the AAP does at a national level that also benefit pediatricians, but you only will know if you're a participant, if you're engaged. And so they're not doing a good job of communicating.
I applaud you.
This may be before your time. Hold on, Herb. Before your time with SOPM. But do you know how SOPM actually developed? How it got such a powerful thing? SOPM was developed by some, a group of physicians. They made it, and nobody paid attention to it. And then at the different events, at the PCC conferences, at the OP conferences, at the PMI, all these places where you had a captive audience, people would go and say, you should sign up for SOPM. You should sign up for SOPM. They made like little contests and things, and people were signing up for SOPM. And then do that a couple of years, then you got a lot of people. You made it easy.
And you made it easy, and it was personal. Like that was a lot of,
I won't say who the people were, but the people that did do it they were personalities.
Yeah.
But it's very community driven, the SOPM is. But I applaud you because, I'm not a young person anymore. And the younger generation of pediatricians, they're accustomed to being on either LinkedIn or Instagram, and they build communities there. And to them, the idea of I have to log into a portal for the AAP and follow the rules when I want to speak about this or that, who does that, right? To them, it's just not. It's like you talk to a 25-year-old, they're like, don't bother emailing me, text me or send me a message through Instagram. And I'm like, why? There's email. Oh no, emails for grandparents. That's not, we don't look at our email. We only do it for work and school. So the mindset has changed, and the organizations can't be rigid. They need to meet their members where they are in order to maintain them engaged, and that's on them. But anyhow, we wrote a small essay on workforce development in pediatrics, and I think most of us in pediatrics understand that the current trajectory is not sustainable. We can't have it's just impossible for medical students to incur $300,000 in debt and then try to go get a job for $140,000 starting out. That's just, the math will never add up. There is an incredible amount of disparity or injustice, I would say, in the way that the federal government is funding student debt forgiveness. It will fund it for a rural health center. It might fund it for a qualified healthcare clinic. It might give it to my big hospital that owns 85% of the beds in Northern Virginia. And I think they have $2 or $3 billion in endowments sitting in the bank. But it won't let me recruit a pediatrician to a community and be a community pediatrician and offer them student debt forgiveness. Yep. That's a huge disparity. And like I like to say, we don't means test public schools in America. We don't just say the Black and the poor and the this and the that get to go in the door of the public school, but the sons of the doctors and the dentists have to pay a different rate because they can afford it. And I don't understand why the sons and the doctors, the sons of doctors, dentists, whatever they are, whoever they are, have to pay a different rate when they go for medical care. It should not be means tested. If a pediatrician is community-based and committed to taking care of all children in that neighborhood, he or she should get loan forgiveness, like doesn't matter, independent of where they're employed.
Yeah, you know what? Just this year, I had 5 perfect candidates that loved the office. 3 of them used to come to the office as children. I saw one of them when he was born. All right.
That's awesome.
They all, it's possible, it's true. They all would have loved to join us, but they had loans. Since we're a private organization, we cannot get loan forgiveness. I'm trying. We have 65% Medicaid and Child Health Plus. And we provide great service and urgent care service. And, you know, people drive to us from an hour away because where they are, they don't have pediatricians. Yet we cannot get the loan forgiveness. I got somebody as recent as yesterday. Thank you for reaching out to me. Great videos. We love the office. I was able to learn a lot about the practice, and I could see a place for me to grow up there and work as a physician. However, when I see the word however, I know it's over. Right. Unfortunately, I'm not able to join your private practice because I have student loans. I'm currently working at a nonprofit. Sad.
George, but that's what I mean by
I know that. But this is real.
But you have 20% Medicaid or 80% Medicaid. It should not be means tested. We are losing the battle in primary care.
Oh, yeah.
And
well, that's
the policy of the government should be to help neighborhoods have access to primary care, not just the marginalized neighborhoods. Every neighborhood in America needs primary care, whether you're in the rich neighborhood or the rural town in Alabama. You need primary care. So it cannot be these people get it and those people don't get it. People should have a choice of where they go to work and where they make a difference.
You're correct.
So I'll stop at that. And
the federal government should be prioritizing preventative care. Payers should be prioritizing preventative care. And that's exactly what we don't see in pediatrics, of course, and family practice doctors are right there with us, is that we do not get the same kind of reimbursement for the life-saving care that we provide every day.
Yeah,
that's right. And then we have the problem of moral injury, which you beautifully just described at the beginning of the show. You work for a federally qualified clinic in a rural town. You're trying to help children, and you can't even get the bean counters to allow you to put a developmental screen into your workflow. And then you describe beautifully the solution to that. Independent, I'm going to call it smaller, your practice is very large. Small businesses have the ability to innovate and be true to mission without losing their shirts. Larger institutions like your local hospital doesn't really care about preventive care. And they're not going to invest a dime in pediatrics because they can make much more money recruiting an orthopedic surgeon or a cataract surgeon. A cataract surgeon can make $5,000 in 7 minutes. And boy, are people happy when they can see again. Yeah. It's immediate, instant gratification. So you can't, I mean, you can say they're evil. You can call them all names you want, but they're really not evil. They're just making the best choice for their organization. It's a business, but they're not mission driven.
No.
And to remain mission driven, I believe you must be based in the community. And a lot of times you have to be independent because we want to do what's right first. Like George's father says all the time, give them the right care and the money will follow. Chase the money and you'll lose your patients.
We have partners that have been not here for 70 years. The partners that originally started our practice have long since retired, but some of my partners, some of the owners have been here for a long time. And the older partners always say, if it's the right thing to do, if it's the right care to provide the care, and the money will follow. Like, we will figure it out. The money will follow. And that is what happens. Now, in our organization, one of the reasons that we have been able to be so successful in expanding is because of that economics of scale. And I think that is a burden to a lot of people starting independent practice in communities. They are able to stay mission driven, but the financial implications of starting a practice, especially during this time of insanely increasing costs and staff shortages, is very burdensome. And so that often keeps people from starting those independent practices. I do think there is a role for practices to join together and support each other, because we can benefit from each other rather than joining a private equity or joining the hospital system where they do not care about our mission.
You know what
But
that
joining
is?
with other pediatric groups that do care.
You know what
about
that
our
is?
mission.
You know what that's called?
What is that?
It's called a clinically integrated network of independent
Network, yes.
nutritionists.
Well,
Which we don't function that
We
way.
did that in New York.
That way, but you're right. That is what it is. It's clinically
so
integrated.
you're absolutely right, but there's all kinds of different ways of doing it. So you could become a group without walls, a mega group. You can become one practice that has 5 different offices in different locations. You can join a CIN. You can join a coaching group, and I'm not going to plug in our coaching group, but it basically is, you may not be ready to get married to another group, but you benefit from having 10 pediatricians looking at your problem and saying, oh, we did this and that went away.
Yep.
When you're solo or 2 or 3 persons, you might spend days trying to figure out which way to go and then not go the right way, and then it costs you a lot of money.
Yep.
So I don't care which way you use, but we need to talk to each other. And choose whichever marriage arrangement suits you best. If you want to live with a person, if you want to date with a person, if you want to have a Catholic wedding, if you want to have a Muslim wedding, yours, it doesn't really matter, but get out there and talk to other people. That's what's important. The power of we is very powerful.
Absolutely.
And so it's not so much how you structure it, is that you're talking to like-minded people who care about the mission. That is the key.
You can call it a philosophy or whatever you'd like to call it, but it is one of my strongest beliefs that our pediatrician community has all of the creativity that we need to solve our workforce issues. The missing component is that we are not all speaking up. We are not all working together. We are not all using that collective voice. And that has been my grander mission, not my chapter mission, but my grander mission as a pediatrician, as a community pediatrician in the community, is to get other pediatricians to recognize their message and their power and use that voice. Because if we're not all doing it, then we're not going to hear those solutions and we're not going to make those breakthroughs.
You know why that happened? You know why that happened?
Why did that happen?
Because your mentors, the people, the legal people ahead of us, they all brainwashed everybody to believe you don't talk about business with other doctors. You don't talk about this for legal fears, for repercussions of collusion, the Stark laws, all these bad things. So better off to just not talk to you.
Yeah. In my old organization, that was, you didn't get to talk to anybody else about your salary or your bonus and every year when they would say, gosh, you're just not seeing enough patients, I would want to look at the numbers because I'm also a data person. So I want to see what's the problem? Where is the, where am I falling out? What do I need to do better? And they wouldn't even show me the data. And I tell younger physicians now, that's a big red flag. If someone's not showing you numbers, if they are not open with their numbers and what people are making and how they're earning, and then that's a red flag.
Oh,
So,
yeah.
Right there.
no, Nolan, the one of the keys of advocacy, because the legislators, they don't want to hear the problem. They want to hear solutions. So what is the solution to these workforce problems that are unique to pediatrics? What would you propose? 1, 2, 3 that would be game changers?
Ooh, that was a hard question. Just because I have to think about where I'm at. The first one is increasing reimbursement for primary care. We need to flip the script on how we reimburse doctors. And I know that's a big change, but we are the ones that are preventing the life-threatening catastrophes that cost so much money. We're the ones that are helping payer groups, whether that's Medicare, Medicaid, or whether that's Blue Cross Blue Shield. We're the ones helping them save money. We should be the ones receiving that benefit, because while it is not about money, you sure can't do a lot of things without money. You know, I can't hire staff and retain staff without that money. So we need to flip the script on reimbursement. And that includes supporting all primary care doctors with things like loan reimbursement.
Yes.
You know, so if medical school is going to continue to cost hundreds of thousands of dollars, that is going to continue to narrow which physicians can go in to medical school, and therefore which come out of medical school. And that is going to continue to shift a lot of physicians coming out of medical school to go into those subspecialty tracks where they can be very procedure focused, just so they can make money back to pay off those medical school loans. So either we need to say, if you're going into primary care, we're going to get rid of that, or we need to change the way medical school is funded for all physicians. And so those are the two big things. And again, it's not about the money. It's about what you can do with the money. Like, you can only do things with money.
You know what's very sad? You know what's very sad? I have medical students that follow me. I'm one of their preceptors. So I have a new student every single month. I've been doing it for 3 years. I get 10 students a year, and there's 6 of us that do it. So there's 60 bodies a year that walk through our office and are exposed to a unique type of general pediatrics office: primary care, urgent care, chronic care, whatever kind of care you want. The end of the month, they say, well, we never knew pediatrics could be like this.
Mm-hmm.
All right. So that's a good thing. But I have not met one kid, not a one, that said to me, yes, I want to go into pediatrics. They all want to do procedures. They all want to do interventional radiology. They want to do surgery. I get a handful that want to go into family medicine, but that's about it. It's all specialty, dermatology. How many specialists does this country need?
All right, so I found you one with a group that's 170. So, but we always get into this rut. So let's move on. So you did two of the very important questions. The third one is and I have to say it, how do we keep women from being morally injured in our workforce and giving up after 3 to 7 years in practice? Because that is an alarming trend, because pediatrics is a woman's specialty now. Oh, yeah. And if they're spending 11 years to train and they last 3 to 7 years, and then they don't want anything to do with it because they're just so overwhelmed and unhappy with not being able to do what they feel is necessary to be a good doctor. How do we solve that? Now,
that one I think is going to be even tougher. And I'll tell you why. There's one piece of this that I think is missing from your article on moral injury and how that affects women. And it's a piece, it's missing because not a lot of people are looking at it. It deserves more research. It is my belief, based on talking with women pediatricians around the country about their voice and their messaging, that a lot of women that come to pediatrics, that choose community pediatrics as a specialty, come with a history of trauma. So when I speak to women groups about their voice and finding their voice, I often reference my own past as a survivor of childhood abuse and how that shaped my voice, my internal voice, and my perception of myself at a young age. And when I speak to these groups, what I am increasingly not surprised to find is that so many women resonate with that message because they also had a history of some form of trauma in their childhood or early young adult life. And that trauma often is what causes us to see pediatrics as a way to give back, to make a difference in other kids' lives when that difference wasn't made in our own life. And so that's what drives a lot of women into primary care. But it also, I think, affects our ability to advocate for ourselves, for the resources we need to continue to provide that care, because we don't recognize that we are worthy of those resources. We don't recognize that we do have a position where we can speak up and demand more because of this history from our past that is still on us, and some of it that we still see in our communities now, right? Where women's voices are just not as easily recognized as men's voices. I don't know about your practices, if you've ever had this experience where a group of you call the ambulance because you have a kid that you are resuscitating actively in your office, and a group of emergency workers shows up and then questions whether or not your diagnosis is accurate, questions whether or not this child should be taken by transport to the hospital. Are you sure? Are you sure? In front of the family that you have just convinced them. And that should not happen. And it definitely happens in our practice, more so with the female providers. If it's you're young female provider, you're a lot more likely to be questioned on your management than you are an older male provider.
That's true.
And that shouldn't be happening. So we are internalizing these voices from our past and from our current communities that we are not enough as we are, that we are not powerful, that we cannot demand more, that we are not worthy, and we are not using our voice collectively to demand more, to demand those resources. And so I really think it starts with convincing community pediatricians, helping community pediatricians to recognize their value. One of the things that I hear from my nurses regularly is just about, simple vaccinations. Sometimes they're just like, oh, it hurts my heart to give this 4-year-old vaccines on their birthday, which we try not to get people to come in on their birthdays because that is kind of cruel. But, it hurts my heart to give this kid vaccines. I said, one day you're going to get to heaven and you're going to find out all of these kids whose lives you saved by giving them that vaccination. We don't see it in preventative care. It's not that cataract surgery where people are like, oh my gosh, I can see. If they didn't lose their vision to begin with, you can't see it. You can't see it, but you are making such an impact in the lives of children every day that you just won't know. And we need to start by convincing women physicians that they are those change makers in their community, and they just need to speak up and use their voices collectively.
I think it should be all physicians.
I call that ringing the bell. After your second HPV vaccine, someone in the office ought to ring that bell, because that's one less cancer event we're going to see in the 20 years ahead of us.
Do you do that in your office?
I don't, but that's
a great idea. I might start doing
ring the bell after the second HPV. Ding, 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 ding. Everybody clap. Because it's a miracle of modern medicine.
Yeah, that's a HIPAA violation, my friend.
It is no HIPAA violation.
You just did. Yeah, I'm ringing a bell because Johnny got his second HPV.
No, everybody knows this in their room. Also, they're HIPAA violating when they leave the cancer ward and they ring the bell and everybody claps. and all the other cancer
But
patients.
again, this is the kind of stuff that's indoctrinated in people's head.
No
Somebody will
HIPAA
tell you it's a
violation.
HIPAA.
It's
I
just
assure you.
we refuse to have fun, and we
Yes,
refuse
yes,
to,
yes, yes. You're
and
correct.
we refuse to applaud our own success, and we
Correct.
refuse to
it.
tell
That's
people,
it. That's it.
I'm doing great for you, for your kid. They're never going to have a pap smear. They're probably pap smear are going to disappear 40 years from now. They won't have,
Amen.
they won't have to have their cervix taken out. They won't have to have chemotherapy. They won't have to, and when the vaccine for breast cancer comes out, they won't have to have their boobs pinched anymore, just to make sure that that hurts, George. You laugh, but it hurts.
I am sure it
Inconvenient.
hurts. I'm sure it hurts.
And so
But
that will be.
I tell moms, you're not just preventing cervical cancer, right? You're preventing pap smears, you're preventing colposcopies where you had a precancerous lesion and now your child might have their incompetent cervix and they have miscarriages because of that biopsy that they had. And we don't have to do any of that. If we could get everyone vaccinated, we don't have to do any of that. But it would, just like all the other vaccines, it would get missed, right? The scientists, the data nerds like us, we would see those rates of the cancer going down. But the people that never got the cancer, it's not as much of a miracle to them. They don't realize what a miracle it is.
No.
And as it is when you cure cancer, right? So they don't realize it's a miracle that they just never got cancer, because we can do so much. And that's really where our own voices make a big difference. We need to be celebrating that work that we do every day. We need to recognize it.
We do.
Need to
Ring the
celebrate
bell.
it.
Ring the bell. Make people know that you're doing a great job. So I have another a question. Who at the national level is going to advocate for better reimbursement, and has been doing it for decades, for a healthy pediatric workforce? And for, I say this, and I know I'm a comical, and I know I'm a big clown, but if the pediatrician is not healthy, if the mom's not healthy, there are no healthy children in America. Who at a national level is carrying that message today?
Yeah.
Underdog.
So we need to be carrying that message as a group, and collectively that group should be the AAP. But if the group is not going to be the AAP, then we need to have that collective messaging as a group. And I do think there are people within the AAP that are trying to carry that message. It sometimes gets lost among a lot of other messages that are out there. But it should be the AAP as the largest organization of pediatricians. Yes. But and that's the group that has the resources to make that kind of messaging and to get to the people in power. And again, if for some reason the AP can't do it, we all need to get together and do it.
I agree. And I think we are at a juncture, it's changed now or we're done. Mm-hmm. And we need a leader at the national level who will articulate and who is experienced in these issues, articulating and leading the AP.
Absolutely. I agree.
And if we can't find that, then it's time for us to all go somewhere else, create a union. My dad was into cooperative building, so he loves the idea of credit unions. For the life of me, I never understood why the AP never created its own bank. It's called a credit union. Mm-hmm. It's a member-owned bank. There are 67,000 people that make over $100,000 a year. We could all put our money there. We could get better loans to each other. We could get startup loans for pediatric practices. Right?
Yeah.
Whole idea. Makes money for the association, makes money for the members, helps maintain the mission. Anyhow, off the soapbox. Can there be health equity and access to care if the specialty of pediatric disappears in America?
I think that question answers itself. We know that children that receive their kind of Bright Futures recommended evidence-based well child visits are more likely to do all the things. They're healthier, they're less likely to have problems with their chronic diseases, but they're more likely to stay in school, they're more likely to attain higher education, they're more likely to get a better paying job when they're older. And a lot of it starts with their health as children. And if we don't have pediatricians that they can access in their communities that are providing those services, then it's a cycle, right? And they don't achieve that level and it comes back. Unfortunately, the communities here in Alabama that have the highest rates of risk factors for disease, so poverty, but also environmental exposures, environmental toxin exposures and such, those are the communities where there are the fewest pediatricians, and we have the hardest time getting pediatricians to come to those communities. That has been the mission of my practice, is to put pediatricians in places and support pediatricians in places where there's really need in rural Southeast Alabama. But we need pediatricians everywhere, in every community. Every community needs pediatricians, and we need pediatricians of all types. And that goes back to medical school and figuring out the process of how we do this, because medical school is such a barrier. The financing of medical school is such a barrier to so many pediatricians or so many, what could be future pediatricians, that we are really selecting out which pediatricians we need. But in order for those cycles to break, you really need pediatricians of all types, of all genders, of all races, of all socioeconomic backgrounds. You need people that can really impact those communities, people that those communities will trust, and that is still a barrier,
Yes,
that's difficult.
Unfortunately, there aren't that many pediatricians coming to pediatrics. It's all nurse practitioner based. Now, I've held on. Our line at the office is primary care when you want it, urgent care when you need it, services provided by physicians. After all this loan forgiveness stuff and not being able to find physicians, I finally broke down and approved to put out an advertisement for a nurse practitioner. Within one day, 4 applications. Now, unfortunately for them, they're all newbies. They're just fresh out of school. They're probably 15 years old. They cannot work side by side with me. I'm sorry. It's impossible, but that's what's happening.
Yeah.
And let's move on to a more cheerful moment. So when we met in Houston, you gave a talk about the importance of the elevator pitch. Could you share your elevator pitch with our audience?
Well, I always have a lot of elevator pitches going on. I'm sorry if there was noise. I always have a lot of elevator pitches at a time. It depends on what stakeholder I run into.
Well, try to convince me to come to your office to work for you.
Oh, that's a good one. Yeah. So I am a community pediatrician in rural Alabama and an owner of a multi-specialty pediatric practice with 5, currently working on 6 locations, and a mission to expand access to quality healthcare to all children of Southeast Alabama. In Alabama, we have 23 counties without a pediatrician, and we want you to be a pediatrician to serve those communities. We will support you in your practice with everything you need to be able to do what only the physician can do and leave on time to go home to see your own family.
And what is the ask?
The ask was for you to come in. I embedded the ask. That was, I don't normally do that. I normally end with the ask, but I did it. I flipped it that time. So there are 3 components to that elevator speech, right? So the first is the introduction. You have to know who you are and say it with clarity. And you don't have to embellish who you are. Being a community pediatrician, being a small business owner, being the president of the AAP, those are already of the chapter of our local chapter, those are already big titles. People understand what those things mean, but you want to own it. If I was introducing myself to a legislator, I would always use my title also, I am Dr. Ernest, and I don't want anybody to refer to me as otherwise if I'm outside of a collegiate setting. But in the collegial setting with other colleagues, I might just introduce myself as Nola. But that's my identity. You know, I'm a pediatrician. I'm a business owner. I'm a chapter president. That's who I am. The second component is that what is the problem, and kind of what your idea is for the solution, but really what is the problem? And the problem here is that we just don't have enough pediatricians. We don't have enough pediatricians to meet the need in our area. But there are a lot of problems. And so we've delineated several of those today.
And then the third thing is the ask.
And the third thing is to ask. And so for this, the ask is to come to my practice, but
and then the
what the solution is.
The salespeople will tell you, frame the ask in a way that the person has to say no, because we're wired not to want to say no. So if I make it in a way that I'm asking a question where you're going to have to say no, like when I asked you to be on the show, I didn't give you a choice. You were going to have to say straight out no. And most of us are kind of wimpy. We don't like to disappoint people. So we're like, okay, what date? Even if we're overwhelmed, but we just don't like to say no. And that's a sales tactic.
And that is a great technique when talking with legislators. So even when you're asking them to support or oppose a bill, especially if you have a specific number in mind, you want to frame that ask, like you said, in a way that it's hard for them to say no. So I'm asking you to support the children of your community in Southeast Alabama by saying yes to this bill that would provide adequate Medicaid funding. And if you can get them to not have to say no, because no one wants to say no, but no one wants to say no to supporting children.
Yes.
Right.
Right.
And so like, no, I don't want to support children is an ugly thing for people to say. And so make it that they can't say no to you.
Great. Now, what have I not asked you that you want our audience to hear?
I think we came around to it several times. You didn't ask it, but we've talked about it. And that is each individual pediatrician has a unique identity, a unique message, and that identity and message combined, that is what I call their voice. That is their voice, their unique voice. And all of our voices are valuable. And for our world, but especially for the pediatric workforce in the United States right now, to be a better place, we all need to recognize and use our individual voices.
Great. Excellent. Thank you so much for your time. Thank you
for
taking
fun
care of
talking with you guys this morning.
Thank you for taking care of the kids in rural Alabama and all your advocacy work that you're doing as a chapter chair out there. It's always very, very enjoyable to have a conversation with you.
I'll come work with you.
Yeah. You almost convinced me that the beaches are nearby.
And not just the beaches, but the best beaches in the United States. Our beaches are white sugar sand, clear emerald green water. They're beautiful.
Yeah, I'm sure.
Oh, good.
And you can get loan forgiveness at your place, right?
It's even tricky to get it here.
You're kidding me.
Mm-hmm. And so we've been working this year with our medical association to break down some of the barriers in our state to get state loan forgiveness, but the federal loan forgiveness is even tricky to get here because there are so many barriers that you have to meet. And we take care of also at least 50% Medicaid. It's a little different in each of our locations. In one of our locations, it's over 60% Medicaid alone, not including our CHIP program. And and we still have a difficult time taking care of Medicaid.
So you guys are a safety net practice.
We are a safety net practice, and it is difficult.
If you close up shop, these people have nowhere to go.
Mm-hmm.
It's a problem.
That is the tool that we use to advocate for funding, but it is difficult, and so there are definitely barriers to getting that loan forgiveness. That even for safety net practices in rural parts of the United States that are taking care of the underserved populations, even for those practices, it's hard to get that loan forgiveness, and it's hard to get tax credits and all the things that people claim would help recruit physicians. it's not always that simple. And so we're working on breaking down some of those too.
All right.
Awesome. Thank you so much for your time
Thank
today.
you, guys. It was nice to talk with you this morning.
Okay.
Great. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.